invite Dr. Saurabh LUTHRA for his next talk, Rrhexis Follies.
Thank you. So let's straight away start this. We all know CCC plays a very important role in our newer generation cataract surgeries. Where I was trained, I was told 3 steps in cataract surgeries are very important: a good Rrhexis, a good incision, a good Rrhexis, and a good hydro. That's what makes your life convenient in your surgery. So yes, it's often underestimated until it goes wrong. A good Rrhexis forgives many sins, but a bad one demands panache. Ideally, it should be a 5.5 mm Rrhexis. You can alter it depending on the size and shape. Should overlap the optic by 360 degrees. It should allow easy nucleus manipulation, stable IOL placement, least or reduced PCO risk, and acts as the foundation of the surgery. We've started from here, we've reached here with the newer machines, of course. So as I said, a smaller axis, anything less than 4.5 millimeter, increases the risk of phimosis. A larger axis, more than 6 mm, potential for IOL decentration. An eccentric Rrhexis, which can be a good sized, but an off-center Rrhexis disturbs you, especially when you're planning a premium IOL, especially trifocals or EDOFs. Runway Rrhexis, tears extend uncontrollably to the periphery, a radial tear which can lead to a capsular rupture, and an incomplete Rrhexis ends probably not joined properly, has a risk of extension, especially at the time of hydro. Smaller Rrhexises, how it can really happen? Fear of extension. You start really close to the center, inadequate visualization at times, and early beginners, of course, we've all made that mistake. The complications: difficult nuclear rotation and emulsification, risk of capsular contraction syndrome. Management wise, you have to have all these newer tools like the micro scissors and the forceps, tratas, and the micro the newer forceps which goes through the side port, so that you can really help them extend well. Stretching with the hooks, if at all it is really advanced phimosis. Larger overconfidence, keeps on going farther. Poor anterior chamber maintenance at times, and an excessive flap pull. IOL, the problems associated are decentration and an haptic exposure, which can at times lead to negative dysphotopsias. Pearls marking on the cornea with a 5.5 millimeter marker before the planned Rrhexis, and a better control with microforceps with cystitome alone. Eccentric, a good heart-shaped Rrhexis, but it can cause IOL tilt and optic edge glare, a cosmetic dissatisfaction in the premium IOLs. How to fix them? Try and the visual clue can be of the first Purkinje image, the corneal reflex, use of the marker as we discussed before, and there is no harm staining the delineated capsule edge. Runaway Rrhexis, we are all scared of these Rrhexises at times when they start going in this extreme. High intralenticular pressure, sudden chamber fluctuations, signs a sudden uncontrolled extension towards the periphery. We've all had this in our practice. I'm sure Argentinian flag sign occurs in intumescent white cataracts. Whatever best you do, maybe a IV mannitol before or whatsoever, but it can still happen in the best of the hands. Prevention: decompression of interlenticular fluid. I'll be showing a small video later on that. Staining: I tend to stain all my capsules here, especially in cases like this. Initiating Rrhexis with paracentral area, and regrasping Rrhexis edge, quickly converting to can opener if at all needed. Most complicated and the difficult ones are the pediatric, and the complicated cases are the highly elastic anterior capsule. These are the biggest challenge in the pediatric cases. Tendency to run off is much more higher. Fugoplasma blade used at certain centers, it tends to give you a good sharp edged Rrhexis. High speed vitrector for vitrectorrhexis, and good use of OVDs with higher viscosities like the Helon GV or 5. Tips: shift to a higher magnification, firm chamber with cohesives, viscoelastic, and a two-stage technique can be helpful. These IOL demands a good Rrhexis, so these are very sensitive towards centration. So the Follies impact decrease efficacy of multifocal zones, astigmatic correcting, offset in toric IOLs can happen. Visual aid: split image of a centered versus decentered IOL, especially in the other eye if it is something like that. So tip here would be a central Rrhexis over visual, fixing the center over the visual axis, the first Purkinje reflex instead of the pupillary center. Always stain the capsule, use Rrhexis markers here. Good micro Rrhexis forceps and a tratas, of course, allows better control at times. Then the cystitome maintains stable chamber to avoid runoff. A two-stage Rrhexis, as we discussed, can or rather be helpful in white and pediatric cataracts. These are the available tools. I mean, certainly femto is one of the best available options as of now, but of course. So this is something what we've really discussed. The tips again, milking technique is very helpful in the white cataracts. Staining of course is required. Spiral Rrhexis in rescuing the radial tear. Scissors and fibrotic capsules. Scissors for the fibrotic capsules. Just a small video how the little maneuver comes into place. I'm running a little faster here. This is 4 times the speed, don't worry. This is how I don't operate that fast. Little demilking is done here. You pull it and pull it right opposite. I'll be showing it in a little slow motion here. And it comes back to you. So this really helps. It's a good maneuver. Practiced, it will certainly come with practice. And where you feel that you need to go on to a higher magnification, you go, and so that you have a good centered, good edged Rrhexis. One more smaller video. This was again a phacomorphic glaucoma case with a very shallow AC. Small side port entry, careful so that I don't puncture here. Staining of course helps. Form the AC, enter slowly. Here I am somehow more comfortable using a cystitome. So I've just picked up the flap. I go in with the 27 gauge, nothing comes out. Go with the 23 gauge, just finishing. Now you can see those fluffy little cortex coming out. You have to be very careful while demilking these cortex, because here also there are chances of, the Argentinian flag size are very high. I will just show one more thing. In cases like this, once you finish the Rrhexis, I've used everything here, my atratas, my micro SS forceps, and I thought it is comfortable here. Again, it is so fibrotic that I have to go very slow here. I was losing my patience, but again, God was kind. And in these particular patients, before going with the phaco probe, you take a IA probe in, again do the demilking more comfortably so that you have the space for the nucleus to be rotated. Final thoughts, it can make or break your cataract surgery. Even experienced surgeons encounter Rrhexis surprises. It is forgivable only if we learn from them, and the key is anticipation, skill and control. To summarize, assess before you start lens type, chamber depth, respect the capsule, it's fragile and unforgiving, use the right tool at the right time, always be ready with the plan B. A good Rrhexis sets you free, a poor one changes the rest of your surgery. Thank you.